The first question is how is difficult to fight against malaria here?
It's not very difficult, but it takes a lot of time. It takes a long time. So, if you want to summarize about the situation here on the border, it basically takes 40 years. So, since we arrived in 1984 to 2024, then, yeah, 40 years. 40 years to change from a situation where malaria is killing the highest number of people and it's the number one problem to a situation where it's not a problem anymore and people don't have to suffer from it. So it's not very difficult, but it takes a long time. And it's not cheap because you have to invest in many things, in human resources, in logistics, in medicine and things. Now, it's easier for falciparum, which is the dangerous type of malaria. It's easier because you just need to provide the people with diagnostic and treatment at the doorstep when they live, where they live, in their village. And if you do this, the falciparum malaria goes away. Because if you treat early, it doesn't have time to transmit to the mosquitoes. So the transmission goes down and then so that's what we did on the Thai side with the Thai Ministry of Health 20 years ago, in 2000, it works. And then we done in the current state, and it works. So it works. Why they don't do like this in Africa, I don't know. It's another subject, but this is not a new idea. It was developed by the old malariologists in the beginning of the 20th century. But it has never been used really seriously in practice. There can be some reason why. We can elaborate on that later. So that's for falciparum. And Vivax, which is very common here and in South America, it's a bit more difficult because for Vivax, when the patient have fever, when the patient start having fever, they already transmit. So even if they come very early, the first hour of fever, they have already transmitted to the mosquitoes because it's a different parasite than falciparum. So it's more difficult to cut the transmission by early diagnosis and treatment. So how to eliminate Vivax? That's a question which is difficult to answer because no one really knows. We don't really have a strategy for that. We have to try things. We have to study it. We have to try different approaches. And, what we are for falciparum, we have the tool that we need. We have the medicine, which is okay. We have the test, which is okay. We don't need more tools. But for Vivax, we have the medicine to treat Vivax that makes you sick, that makes you fever. We have the medicine. But for the stage of the parasite, which is different than for falciparum, there is an additional stage in the parasite of Vivax. It's called hypnozoite. It means it's a form of the parasite which is hiding in the liver for many months or many years. Falciparum doesn't do that, but Vivax does this, and then it comes back again and again and again. So when you hear the whole story of the soldier that went to war in Korea or in Vietnam, and they come back and they have malaria coming back again and again, it's Vivax. It's not falciparum. Falciparum doesn't come back. Vivax does come back. The problem with this is that that liver stage, which we call hypnozoite, the parasite hiding in the liver, is very difficult to treat. You cannot treat it with ordinary drug. You need specific type of drug. And there is only one of this. And this was invented, after the Second World War. So it's an old drug. The problem with that drug, called primaquine, is that in the people who have the Fava disease, the favism disease, the disease that is well known in Italy, this drug causes the destruction of red cells and become anemic, very pale, very dark urine, and and can kill people. So we have a problem, because if we want to use that drug, it's the only one we have for the hypnozoid, we have to detect who has this disease or not first. And it's not easy to detect. It's becoming easier, but it's still, you need some tests, and then it's not cheap, and so it's a complication. It's not impossible, but it's a bit more complicated than falciparum. But the interesting thing is that there is another drug that we could use. It's called tafenoquine, and it's like primaquine, so it's the same family of drug, but instead of being a drug that you need to take every day for 2 weeks or more, which is nobody takes 2 weeks treatment, it's boring. This one is a single dose, so it's one dose, finished. So it's really nice. It's really good drug, and we know that drug very well, and it's been around but we cannot use it because it's not available. Why it's not available, I don't know. No one can explain to me why we cannot get it. It's registered in the US. We don't have malaria in the US, or very little. It's registered in Australia. Why Australia? It's registered in Canada, but that's all. It's not registered in the country where you need it. And it's not being sold by the laboratory where it's needed. Why? Again, I don't know. I think it's a mixture of reasons, probably. A mixture of fear, because that to use this drug, you have to have the test for favism, to detect the people who cannot take it. So the pharmaceutical industry probably doesn't want to invest into the strategy because it's going to cost money, and people with Vivax don't have money. I don't know. And other reason maybe is that these people are not competent into calculating what's the need. They don't measure the need. They don't realize the need of it. They only think about the return of investment and money making or something. That's my interpretation. Nobody told me that. But I don't see any other reason. So I'm fighting, I'm screaming, I'm asking the policymaker, please give us access to this drug, because we need it. Why? Because if we have this single dose drug,
so according to you, according to the work of your unit, one hand you working with the Burmese refugees or Burmese people coming here.
Yeah.
Which is the main problem they have on the other side of the border?
You mean health problem?
Health problem.
Not easy to answer. I think that in the last 20 years, or in the past, the main problems, the kind of problem that affect the population that move from Myanmar to Thailand, and the migrants and refugees and displaced people, most of the problem, the most serious problem are infectious disease. So communicable disease, malaria, TB, other communicable disease directly. Now the situation has changed quite in the last 15 years, and you can see more and more chronic disease, like diabetes, obesity, cancer, hypertension. So if you ask me today what's the most common health problem that they have, it's a bit difficult for me to answer. My perception is biased by what we do. We look at, we treat and we address some specific problems which are mostly communicable, tuberculosis, malaria, but also we do a lot of mother and child health problems. So we see a few other problems. Now overall in the population level, but first of all, the thing to say is that this population of people migrating from Myanmar for different reasons, economic reasons, health reasons, political reasons, if you look at the population overall, my impression, but it's a bit subjective, I don't have real data on it, but I think I have a perception of what they are not in a very bad health situation. So the health situation of this population is not worse than some other population in the world. Now, some of the indicators that we have, for example, if you look at the number of women who died as a relation to pregnancy, so we call it maternal mortality. This is one indicator that tells you the health of the population. The maternal mortality in this population is not very good. It's a bit higher than it should. It's a lot higher than it should be, but it's around 200 women per 100,000 live births. So 200 women died for 100,000 baby born alive. In the UK or in Italy, it's about 5. So it's a big difference. It's a bit higher, it is higher, 200 per 100,000 is higher than in Thailand, and it's higher than in Myanmar official figure, which is what they are. Why is that? It's a question of access. So the problem of the population of migrants and other displaced people is that it's not that they have more health problem than you and me, but it's that they cannot access healthcare. So they cannot easily access a doctor or a hospital or a clinic and say, hey, my throat is aching, or my head, I maybe have blood pressure. They cannot access, it's a difficulty to access the healthcare, and that's a big problem. So what we are trying is to increase the access. So opening clinic that's free for them, that is friendly, so the people speak the same language, same culture, they are not afraid to go, but still they have access problem, because to go to these clinics that we have, they need to travel, and during the travel they can have problem with the papers, the status, the police checkpoints. So one of the difficulties is to increase increase the access to health. Now, in terms of communicable disease, malaria is not a problem anymore. So, last big migration of political refugees in 1998, after the big problem in Rangoon, when all the students came on the border, many of them died, not because of the fighting, but because of malaria. 1988, 1989, 1990, so that's a long time. Now, a lot of people come, they don't die of malaria because there is no more malaria. So, in a way, their situation has improved. But there are other problems, like tuberculosis, for example. We have a lot of tuberculosis. And tuberculosis is a much more difficult problem than malaria, because it's a 6-month treatment, it's very contagious. People can carry tuberculosis with them and spread and contaminate others for many months or years before they get treatment. Anybody can get tuberculosis, even if you have BCG vaccination, anybody can get it. So it's a much more difficult problem to reduce and to deal with than malaria, for example. So tuberculosis is one. And then what I am worried at the moment is that since the trouble started in Myanmar 3 years ago, with the change of regime and things, and the collapse of many systems, one of the programs that has suffered is the extended program of immunization. So the immunization of the children population against some common disease like polio, pertussis, whooping cough, diphtheria, and tetanus. And many children have not seen any vaccination yet. So what I'm concerned is that these diseases maybe are going to resurface and restart again and maybe create epidemics. So that's a concern. It doesn't happen yet, but it's a concern.
The last question, very quickly.
Yeah.
You used to say, just 2 minutes, you used to say that disease don't have passport. What do you mean?
I mean that some people are thinking that by putting a wall or putting the guard with the guns, you prevent the communication between the country and the next door country. And this is an illusion, because disease don't have passport, and it means that they can travel across the border freely. They don't need visa. They can So communicable disease can always travel anywhere without problems, especially the disease who are transmitted by mosquitoes. Because mosquitoes, they don't ask a visa to the border government, they just fly. And I think that it's a humanitarian scandal or something. It's not normal. We should have access to this drug. So it's not a new drug. It's an old drug. We know the side effect. We know the dose. We know everything about this drug that we need to know. We don't need to wait for more studies or more. We know everything. We know when to give it, not to give it, how much to give it, and we don't have it. So and they need it in South America because they have a lot of Vivex, in Brazil and other big countries in South America. Outside Africa, Vivex is the most common malaria parasite. Most common. In Asia, in India, you have a lot of Vivex in India. So Vivex is not itself a priority because it doesn't kill people. You know, it's not like falciparum. Falciparum, it kills hundreds of thousands of children in Africa every year. Vivex doesn't kill people. So it makes you sick, you have fever, you're shaking, and you take a bit of chloroquine and then that's better. But it's coming back. And if you accumulate the work hour, the hour lost, the time you can't go to school or you cannot go to work, it has a weight on the economy of the people, of the population. Plus, what we have shown here in this scenario is that Vivex, okay, it doesn't kill you, but if you are a pregnant woman and you get Vivex, then you don't die, but your baby, you may have an abortion. You increase the risk of abortion. And an abortion is not nice. So it does have an effect on the life of people, which is not negligible. So we should suppress the Vivex as well. And